a real need for better biomarkers for patients with triple-negative breast cancer and other subtypes of breast cancer as well, to try and identify those who are going to benefit the most. I think the key to finding these biomarkers is really going to be to study those who are responders and non-responders to the current immunotherapies that we have, the approved ones as well as the ones that are in current clinical trials. And part of the challenge, I believe, is that the current biomarkers we have are just very inconsistent. And part of that is because they change with treatment. So when you look at PD-L1 status at the beginning of someone's therapy, it could very well change toward the end. In addition, when you check someone's PD-L1 status at the beginning of treatment, depending on where that biopsy is from, could actually influence the outcome of the test. So if you're looking at a patient's liver met biopsy versus their lung met biopsy, you're more likely to find PD-L1 positivity in their lung biopsy and a negative result in their liver biopsy, and that would actually dictate what you choose to move forward with in terms of treatment, and very much could actually, mislead you with regard to what is going to respond and what is not going to respond when you give them that immunotherapy. So I think the really important part of this is to continue to enroll patients in clinical trials that are going to allow us to collect biospecimens to do the research to find the better biomarkers, because I don't believe we've actually landed on any really good ones yet. And the research of those responders and non-responders is going to be what helps us find those stronger predictive biomarkers. Hormone receptor-positive disease is a really big challenge when it comes to treatment with checkpoint inhibition. I think we are only starting to really understand the tumor immune landscape and how it varies within that subtype of breast cancer. So what we're starting to see is that patients with luminal B hormone receptor-positive breast cancers actually have more immune hot tumor microenvironments, and these are actually the patients who stand to benefit from immunotherapy, whereas the luminal A patients are the ones who actually really need more of a transformation of their tumor immune microenvironment to get them to be better responders. And I think CDK4/6 inhibitors really present us with an opportunity to understand how we can use these drugs as immune modulators, and even in the luminal A patients where they're actually highly immune suppressed, as opposed to the luminal Bs, which have a more immune hot tumor microenvironment, those CDK4/6 inhibitors we're finding have tremendous potential to transform the tumor microenvironment. Now it's just about understanding which immune cells are being modulated by those drugs, and how does that actually prepare a tumor to be more responsive to checkpoint inhibitors. And so really this is going to be about understanding how to sequence the drugs and how long to give, let's say, CDK4/6 prior to coming in with checkpoint inhibitors. And I think that's where we're seeing the most promise, where CDK4/6 inhibitors really can be used in that way, as opposed to how we're using them now, which is actually more of an anti-tumor medication. We're using them in the more immune modulatory setting when we're pairing them with checkpoint. And I think that's how we're going to gain traction in the hormone receptor positive patient population. I think what we're faced with now is that in the Keynote 522 trial that led to our FDA approval for checkpoint inhibition in the neoadjuvant setting, we have checkpoint inhibitors being used both neoadjuvantly and adjuvantly. There's very little to discern where the real benefit is going to be. And looking back at some of this analyses of that trial and many others since then, we're starting to learn it really seems that upfront neoadjuvant treatment with the checkpoint inhibitors is where we're getting the most bang for our buck. And there are very few patients who are really going to benefit for use of the checkpoint inhibitors in the adjuvant setting. And so I think what trials like Optimize are going to help us understand is who are those patients who actually need additional immunotherapy adjuvantly? Is it those who have residual disease? How are we measuring that residual disease? Is that going to help us decide whether we need to add that adjuvant checkpoint inhibition? And really where we're going to see the most benefit is upfront neoadjuvant. So I think Optimize is going to help us figure that out, as well as other trials that are ongoing, looking at how the immune response varies across, neoadjuvant versus adjuvant use. As we're using these therapies more and more, we're finding the toxicities are actually more abundant than we had anticipated, and especially in the neoadjuvant setting where we're curing disease, it's a lot to ask of patients to take on that risk of having a lifelong autoimmune disease because of a therapy that cured their breast cancer. So we really do need to do better with figuring out how to balance that. And I think in terms of predicting toxicity, there's a lot of work going on to try and figure out how can we do that. A lot of people believe that there are certain ways we could measure initial cytokine levels in response to checkpoint inhibitors to predict whether, if someone has a very reactive immune system, then perhaps we could stop the treatment at an earlier time point to prevent that subsequent side effects from really plaguing those patients. But I think this is a real area of need in terms of research to try and figure out biomarkers to predict this particular aspect of use of immunotherapy. And I think as of now, we really just have to think very carefully about which patients we choose this regimen for, because the way it stands now, we're giving them a lot of therapy, and it's not without risk. And so I think we need to watch very closely on their labs to make sure we catch things early on and stop the therapy if we do see development of different autoimmune and immune adverse events. And for now, if there are patients who maybe have a lot of other comorbidities, especially comorbidities that would make an addition of diabetes or adrenal insufficiency much harder for them, we have to weigh that and ask ourselves, does it really make sense in this patient to take that risk, or can we actually do well by them and achieve what we're trying to achieve, which is cure, without necessarily exposing them to that risk. In the community, when there are still many opportunities to refer patients for clinical trials where that's the only way we're going to answer all of these questions. I think as a field in breast cancer, we are still pretty far behind many other solid tumor types when it comes to immunotherapy, and that's because there's a very different immunobiology that occurs within breast tumors that we're only now really starting to understand. And once we have a better understanding of that, we will come up with ways to transform our field with these really important therapeutic medications. But it's really going to be about participation in research so we can better understand it and get to that endpoint.